So let us discuss about shock thoda sa. Shock, well, let's see about the types of shocks. We have hypovolemic, this is due to blood loss or due to volume loss. Volume loss can occur in various conditions like nephrotic syndrome and burns. We can see third place sequestration and overall diarrhea or dehydration due to any other cause. Then we have distributive shock, anaphylactic, neurogenic. Neurogenic means following spinal trauma. Then we have septic shock, where there is a foci of infection, and then there are feature of all three types. So what's the third type? So I'll write this as the fourth one, and for the third one I'll write here cardiogenic shock. In cardiomyopathy, in congenital heart diseases, in carditis, constrictive pericarditis, and tamponade, we can see. So here goes the type. Now what are the stages of shock? So we have compensated and we have decompensated. So the factors that we see are, of course, the vitals, the heart rate, the respiratory rate, the BP, and then the organ perfusion, and then the volume status by the urine output, and then the mental status or organ perfusion. We see two organs basically. Mostly we see the brain. So we see altered mentation, and then we also see kidney, which is by the urine output, the brain, altered mentation, and there is another special vital in case of children, that is the capillary refill type. So in compensated failure base, the cardiovascular parameters generally remain normal. So here the BP will be normal, although the heart rate and respiratory rate and capillary refill time will be increased. The CRT is normally more than 3 seconds. The urine output will be normal, and the brain and or mentation or the sensorium, the patient will be agitated or confused. But in decompensated, all these parameters will decrease. The CRT will be more than 5 seconds. The BP will be, there will be pulse pressure will be narrow. Urine output we will see oliguria or anuria. And in brain basically we can see that drowsiness or stupor or coma can be seen. So here we have also seen the types of shock and the stages of shock, and then there is also a classification of septic shock that we need to know. Septic shock may be of the cold type or the warm type. In cold type, we divided into three basic headings. We divided based on the capillary refill time, on the periphery, and the pulse. So capillary refill time in cold shock will be basically delayed, more than 3 seconds. And in warm shock, it will be very fast. So it will be like about 1 second. The normal it's less than 3 seconds, but it will be 1 second, very flush. The peripheries will be hot, the peripheries will be cold, the pulse will be here feeble, and here the pulse will be bounding pulse. This is as far as the shock goes. Here let us discuss the management of shock now. So first we have to quickly identify the shock by all the features that are there, vitals and clinical findings of various types of shocks. Then what you have to do is airway, breathing, and circulation. Now in circulation and this initial stage of resuscitation, we have to give high flow oxygen. followed by we have to obtain IV access. And if IV access cannot be obtained, like if there is a huge amount of burns, or like the surface is not, or the patient is not stable enough, is agitated, then we have to go, if within 60 seconds we could not establish an IV access, then we'll go for a IO access, intraosseous access. Followed by that, first what we will do is we'll go for fluid therapy, and then at the same time we'll check and treat for two things: hypoglycemia. If it is present, we'll do dextrose 50%. And if there is sepsis, what we will do is we will give antibiotics. The choice of antibiotics is third generation cephalosporin with vancomycin. Now for the choice of fluid, basically it will be crystalloids over colloids. But if we give a huge volume of transfusion, we have to infuse colloids like 5% albumin. The choice of crystalloid will be basically RL or isotonic saline, 0.9%, something like that. What will be the dose? The dose will be, first initial bolus will be 15 to 20 ml per kg. 15 to 20 ml per kg in 15 to 20 minutes. Followed by, if there is no response, we can go up to 20 ml per kg for again 20 minutes, and it can be repeated up to, we can infuse 60 ml per kg in the first hour. Now after that, if it is still unresponsive, we have to classify if it is a warm kind of shock or if it is a cold kind of shock. We've already seen the difference. Basically the main factors that are involved in it are the capillary refill time, and then the peripheries, and then also we have to see about pulse. Now if it is a warm shock, it requires vasoconstriction, and if it is a cold shock, it requires vasodilatation. So we all know for vasoconstriction we use norepinephrine, and we can use high dose, that is high dose is more than 10 microgram per kg per minute of dopamine or dobutamine. And for vasodilatation we use adrenaline or medium dose, that is 5 to 9 microgram per kg per minute of dopamine. So now basically once these are given, if there is still no response, right, if there is still no response, the dosage of noradrenaline and adrenaline can also be, remember, it's 0.05 per kg per minute, and it can be titrated up to 3 microgram per kg per minute. Here, so basically after this is done with, we can classify it as a catecholamine resistant shock. Basically we are suspecting something like a Addisonian crisis, right? So for that treatment we have to give corticosteroid, because there might be adrenal insufficiency which is leading to the shock. Now after that, what we have to do is, if it is still not controlled, we have to see about a few combinations. Like if there is a cold shock plus normal BP, if there is a cold shock with reduced BP, and if there is a warm shock with reduced BP. BP won't be increased in shock, obviously. So now here, what we have to do is, in this case, and in this case, here, since the BP is normal and still the patient is in cold shock, we have to dilate the vessels. So we have to give vasodilators. Vasodilators, for example, we have our nitroprusside, Milrinone. If it is cold shock with less BP, we have to increase the BP. So we have to give highest, we have to titrate highest dose of epinephrine, adding norepinephrine as well. And if this is the